Well, thank you all for coming back. I'm sorry you're all going to be awake now with all the sugar, but it's always great to talk at this conference. Like Vez and others said, this is very different from what we're used to. We're used to talking to stiff professionals who argue with each other, and it's nice to have the commentary that we hear here. I would like to address the issue of hydrocephalus. Not a lot of Chiari is associated with hydrocephalus, but a significant number. And I think it's worth discussing. The thing that you may know about or have noticed about neurosurgeons who are interested in Chiari pathophysiology is that they like to ask more questions than give answers. And this will be no different this time. I hope that this will stir up a few controversies between the surgeons. So hydrocephalus comes from Greek. Hydro means water, cephalus means head. So what you're seeing here is ventricles that are dilated, indicating high pressure, ventricles that are small, in this case indicating low pressure. In this particular situation, there's an obstruction at the foramen of, at the cerebral aqueduct, that's creating backup of fluid in the lateral and third ventricles, and that's what hydrocephalus is. So hydrocephalus is caused by a variety of different etiologies. It's very, very diverse. This is an example of intraventricular hemorrhage of prematurity that caused hydrocephalus. This is a big posterior fossa tumor that caused hydrocephalus. And of course, the treatment of hydrocephalus here is to take out the tumor. This is an infection, it's a ventriculitis that caused hydrocephalus. Here, that's an aqueductal obstruction. This is the aqueduct, and there's the obstruction right here. You can see how dilated the third and lateral ventricles are, whereas the fourth ventricle is small. And these are three examples of different types of cysts in the brain that create hydrocephalus. This one is in the third ventricle, this is in the suprasellar space, and this is in the pineal region. All of these compress the fluid pathways to create high pressure and hydrocephalus. This is a vascular malformation that happens to be obstructing the aqueduct, creating hydrocephalus. And again, the treatment here is to remove the malformation. And one of the more common diagnoses that we see with hydrocephalus in pediatrics is spina bifida. So spina bifida, or abnormal formation of the lower spinal cord, which creates a Chiari II malformation, hydrocephalus, and Syringomyelia. And hydrocephalus traditionally has been treated with a ventricular peritoneal shunt. And the shunt is a piece of hardware, a tube that goes in the ventricle, attaches to a one-way valve, and then sends the fluid through a tube into the abdomen. So the fluid that is in excess in the brain gets reabsorbed in the abdominal cavity. If the abdomen doesn't take it, it can be in the chest, it could be in the heart, as long as the fluid makes it out of the brain. This is the problem, is that when we place a shunt in a child, adults are different, but when we place a shunt in a child, by 1 year of age, 40% of them would have failed and have to have a revision. By 2 years, almost half. And the vast majority would have failed by a few years later, by 10 years. That's a big problem. And this is a problem that has been consistent since the shunts were invented in the 1950s. The same failure rate that occurred in the 1950s is what we have now in children with hydrocephalus. And the majority of these are related to obstruction of the catheter, and the majority of obstructions occur in the ventricular catheter, which is the catheters in the brain. So this is hydrocephalus, that's shunted hydrocephalus. We've sent out a survey to the senior pediatric neurosurgery community a few years ago, to look at what the understanding is of board-certified pediatric neurosurgeons about hydrocephalus and about shunt function in particular. And these are the 4 topics we're interested in: shunt obstruction, shunt overdrainage, chronic headaches, and slit ventricle syndrome. And I will just summarize it by saying that there was no consensus on what valve to use. There was no consensus on the understanding of pediatric neurosurgeons of what causes shunt obstructions. There was no consensus of what causes headaches and how to treat them. There was no consensus on what causes slit ventricle syndrome or what to do about it. As a background, it's important to know that a pediatric neurosurgeon's practice is 40 to 50% hydrocephalus. So this is a huge deal. So when we put a shunt in a patient, obviously it saves a life. We treat lots of hydrocephalus. If you consider that half of pediatric neurosurgery is hydrocephalus, this is the most life-saving procedure that we do. But also it accounts for the biggest morbidity. If 40% of the shunts are going to break within a year, that's a problem, added to the acute problems of infection and surgical complications. And it accounts for the majority of long-term problems, because malfunctioning shunts can cause headaches can be long-term, etc. So the good news is that alternatives have come about 30 years ago. Instead of doing shunts, people who've come in with obstructive hydrocephalus from obstructions in the ventricular system, are now treated with endoscopy. And if you look at these images, these are the lateral and third ventricles that are normal in this patient. When there is an obstruction at the level of the aqueduct, these ventricles enlarge. So instead of putting a shunt, now we do an endoscopic third ventriculostomy, which is going with an endoscope into the third ventricle and opening this membrane right here to allow the fluid to go and be shunted directly from the ventricles to the subarachnoid space, bypassing the area of obstruction. You're creating a shortcut. And this is an example of an endoscopic third ventriculostomy. So we're looking down to here, and this is that membrane that we're piercing through. We open it, we dilate it, and then what you're going to see once you look there through the hole is the prepontine cistern, which is where the basilar artery is. So that's the opening that we create, and that restores the flow of CSF so that you don't need a shunt. There's the basilar artery. Okay. Now, our interest is Chiari malformation and the association between hydrocephalus and Chiari malformation. And as was mentioned before, the first case presentation, the first documentation by Professor Chiari of the Chiari I malformation is someone with hydrocephalus. So I'm going to poll the medical audience, the neurosurgeons in the room, with this particular patient. This is a child who came in with headaches and papilledema. Papilledema is an expression of high pressure in the head as seen in the eyes. So you look with an ophthalmoscope, you see swollen optic nerves, that's papilledema, that means your pressure is high. And this is the scan. You have a significant Chiari I and hydrocephalus. So maybe the neurosurgeons in the room can tell me what they do in these cases.
Chiari surgery.
Who said that?
Chiari.
Chiari surgery. Because You're not afraid of a CSF leak?
No, as I talked about this morning, I think this is the kind of kid that when you store that CSF or papilloma will go away.
Yeah.
I think he can be a nice way to avoid a shunt as well.
Yeah. BJ, thoughts?
Yeah, I think that's reasonable. I think with the papilloma, I would be worried about doing a Chiari decompression and exacerbating a problem. So I probably would treat the hydrocephalus first. I probably would offer a shunt to start.
A shunt, okay.
A shunt,
Shunt,
especially papilloma.
okay. Michael, shunt?
It's a good question. I despise shunts. So, before I do anything else, I don't know if it would be appropriate, but I think papilloma, we're pretty much set there. Probably a lumbar peritoneal shunt.
Okay. I'm going to give you another piece of data that I hid from you. And let me see if anyone changes his mind. When I took a medical family history, the patient's brother and father had Chiari malformations. And the father actually had a huge syrinx. Anybody changes their mind? So when I looked at this child, I was trained as a resident to shunt these patients. Okay? But when I looked at this child, I said, well, there's a family history here. And it's not a family history of hydrocephalus, it's a family history of Chiari malformation. So the likely issue here is that there was primarily a Chiari malformation that's familial, which, because it's so severe, caused compression of the foramen magnum and obstructive hydrocephalus, just like a tumor in the posterior fossa would cause. And a posterior fossa tumor we treat with tumor removal, not with a shunt. So this is what I did with this case. We did a Chiari decompression, the hydrocephalus corrected, the papilledema resolved, and this was about 18 years ago. So, but you are all right in saying that we just don't know. This is a controversial area because we don't have registries of thousands of patients where we can know exactly what the complication rate is going to be. Because the average neurosurgeon, including myself a few years ago, we were always concerned that if we decompress the Chiari and open the dura without correcting the high pressure, that patient might leak and have a meningitis, and that would be a terrible outcome. But this patient convinced me to go the other way. And when I had this success, it encouraged me to start looking at that more seriously with other patients. But let me show you the data. So Neurological, in a paper in 2011, said, well, it's not a matter of one size fits all. You have a Chiari and you have hydrocephalus, therefore this is what you need to do. You have to separate them from a simple Chiari to a complex Chiari. So for example, he's identified patients who had jugular venous stenosis, which it was what caused intracranial pressure elevation in hydrocephalus, which caused secondary Chiari. These can happen. You have cephalocranial disproportion from syndromic craniosynostosis. That's when your skull is fused at birth, and therefore it can't grow, the pressure goes up. It can cause secondary Chiari malformation. That can cause hydrocephalus. And the treatment is to decompress the skull above, not to shunt and not to do a Chiari decompression. So he says we have to first separate the simple from the complex. Then you look at the various options that we have. We can do a shunt, we can do an ETV, we can do Chiari decompression, and we can treat other primary causes. The data are not huge. I'm going to show you pretty much everything that's in the literature. So this is ETV. And the question is, why do you do ETV on someone with hydrocephalus and a Chiari malformation? Well, the only reason to do an ETV is if you suspect there's an obstructive hydrocephalus. And if there's an obstructive hydrocephalus and the aqueduct looks open and you have an obstruction at the foramen magnum called Chiari malformation, ETV is a reasonable option. So Hayhurst had 16 patients that he did ETVs on. They had Chiari and hydrocephalus. He had to shunt one of them, and he had to decompress the Chiari on 6 others, which means that he treated the hydrocephalus effectively, but he did not treat the Chiari symptoms in some of the patients. And in some, they've done fine. Wu in 2018 had 10 patients with a 20% failure rate after ETV. And that included 1 Chiari decompression and 1 shunt. That means that, 80% success rate. Massimi had no failures in 15 patients. He did ETV, no failures. And there were a variety of case reports, all showing successful ETV in this patient population, which means ETV is generally successful in this patient population. How about posterior fossa decompressions? Well, this is an adult study by Deng et al. That stated that they had Chiari malformation and large ventricles. Now, the only caveat with this study is that most of these patients did not present with symptoms of elevated intracranial pressure. So the question is, were these large ventricles truly hydrocephalus, or were these large ventricles at baseline? And there is no way we can tell at this point. The bottom line is that when he did posterior fossa decompression on all of these with large ventricles and Chiari I malformation, they all had resolution of their Chiari symptoms, and there was no leak, and there were no other symptoms related to the hydrocephalus. This is our study. Our study is in children. There were 14 patients. Most presented with symptoms of hydrocephalus, including headache, papilledema, large heads in babies, and some of them presented with Chiari symptoms. And we did 2 ETVs, 1 shunt, and 11 Chiari decompressions. I'm going to show you the results of the Chiari decompression. Here they are. So 8 of them, the ventricles decreased in size after Chiari decompression. In 3, the ventricles were unchanged in size. However, 10 of them, 91%, had complete resolution or significant resolution of their symptoms, and 1 of them eventually needed a shunt 17 months later. There were no complications, there was no leak. So 90% response rate. Now you say, well, why did these 3 not change the ventricle size? Well, if you restore cerebrospinal fluid flow, such as when you do an ETV, in more than half the cases, the ventricles don't come down in size. And in the other half, they come down mildly, but rarely markedly. It's not like a shunt that collapses the ventricles. So this is not an unexpected finding. So Chiari I and hydrocephalus coexist. We don't know what the incidence is. It's not trivial. The management is controversial, as you noticed by the responses you heard. But different treatments can be successful. The question is, like the chicken and the egg, what came first? Is it the hydrocephalus that caused the Chiari, or is it the Chiari that caused the hydrocephalus? These are the various procedures. Shunts have short and long-term morbidity that is absolutely proven. In 70 years of shunting now, ask any pediatric neurosurgeon in the audience, and should be avoided at all possible. And the choice of ETV versus Chiari decompression is based on presentation as well as surgeon and patient preference. So the question always comes back to etiology. What caused what? How likely is it that there was a coincidental occurrence of Chiari I and hydrocephalus and not one causing the other? How likely is hydrocephalus to cause Chiari malformation? Very unlikely. We have thousands of children with hydrocephalus, very rarely presenting with Chiari malformations. However, Chiari malformations, like tumors of posterior fossa, anything that compresses the foramen magnum can cause secondary hydrocephalus. But again, without large studies, it's very difficult to appreciate this. Now, the caveats, and the reason I'm saying we're always giving more questions than answers, is that there's a really high incidence of low-lying tonsils in normal population. If you look at the Cormac-Marsh study, up to 3% of the normal population have low-lying tonsils, i.e., if you want to call them Chiari malformation. So, and then hydrocephalus itself can come from different etiologies, and sometimes, a lot of times in pediatrics, we see children with enlarged ventricles that don't really have hydrocephalus. This is not hydrocephalus. So when you take all of these together, you can have true and unrelated. You can have someone with hydrocephalus who happens to have a low-lying tonsil because up to 3% of the population have it. And this is where the complicating factors come in. How do you look at a scan and say, is this an incidental Chiari malformation, or is this a true Chiari malformation? It comes back to the original question we keep asking. So I'd like to stop here and thank you for your attention. I'll take questions.
Sorry, I have a question. Can you do the ETV after a decompression?
Yes. Yes, so if the hydrocephalus does not respond, you can. But of course, what people like Vijay and Bez will tell you is that if you do it and the hydrocephalus doesn't respond, you could leak and cause a problem. And that's the reason most people don't want to even try it, because they don't want that risk.